So once again, good evening, everyone. Good afternoon, good morning, wherever you are. And thanks again for joining us. Special thank to Dr. Suarez joining in at 6:30 in the morning from all the way from Stanford. And always Dr. Bolthauser or Eigen, again, a resident panelist for us. I don't think Kish might be able to join us. He's on vacation, but he said he'll try and log in for a couple of minutes or so. We have 10 cases, and we'll start off with our first case, and the chat box is open for your comments, for your questions. We'll start off with our first case. Over to Rainbow, Hyderabad. Devangna, over to you.
Yeah, sure. This is a case of a child who is 7 years old now. He was developmentally normal till 2 years of age with a mild speech delay. At 2 years of age, he had 2 episodes of febrile seizures 6 months apart. Then at around 3.5 to 4 years of age, he started having myoclonic jerks and also started having tremulousness, intention tremors more when trying on writing. So he was started on medication, and at around 6.5 years of age, he had right focal seizures followed by left-sided focal seizures. He was in between free of myoclonic jerks. Now the myoclonic jerks have restarted again. He's 7 years now. EEG suggestive of right-sided frequent hemispheric spike wave discharges of 1 to 2 Hz activity of more than 80% of the sleep record. Examination-wise, his cognition is good. He's going to school. He's walking independently. Mild generalized hypotonia is there. There is writing tremors, intention tremors are present, and right lower limb gets stuck while walking because of some dystonia. So we got the MRI done initially in 2016, and the new MRI was repeated this year.
Okay, so you're sure that the initial one is the same patient?
I think the initial one is of the older. Actually, family history, the older sibling.
Yeah, I think the initial MRI. Yeah, I think you complete the family history as well, so that it will be.
So family history wise, he's the second child. The first child has NCL. He has CLN5 mutation, and this child, at birth, at the conception, he was tested, and he turned out to have.
Okay, we'll wait for the result. We'll wait for the result, but the 2016 scan, is that of this child or is that of the sibling?
Older sibling.
Sibling. Yeah.
Okay. So we'll have a look at the index child first.
Yeah.
Scanned at I think a couple of months back. So scanned at the age of 7 years. Is that right?
Yes.
Okay. Anything on the EEG or just I think that was a description given to me.
There are frequent occipital spike wave discharges.
Okay. All right. Okay, so I have just film images, and you can appreciate that there is some degree of volume loss in the supratemporal brain, more along the cortical regions. The deep brain nuclei, at least on these images, appear to be all right. Possibly some hyperintensity there, but I think the film quality is slightly degraded over there. No focal lesions, no malformations, just generalized cortical reduction in the bilateral hemispheres is what I could appreciate, and some degree of cerebellar atrophy. You can see our cerebellar, the folial spaces are prominent, again on both sides. So cerebral, cortical cerebral reduction and also some cerebellar volume loss is what I could appreciate on these T2 sequences. No malformations, no focal lesions. Diffusion, again, not optimal, but I cannot appreciate any high signal changes on the diffusion weighted sequences. On the sagittal sequence, you can appreciate that the midbrain and the corpus callosum is slightly hypoplastic or thinned out. They also appreciate the vermis volume loss or the vermis atrophy. Pons in terms of the belly is maintained. I think the height is normal for a 7-year-old. And again, some degree of folial prominence over there in the bilateral cerebellar hemisphere. So we're looking at generalized cortical reduction in supratemporal brain, some hypoplasia of the corpus callosum, some regression in the volume of the midbrain, and also of the cerebellum, particularly the vermis. And then this was the gene, Devangna?
Yes, sir. So he has RA-RS2 mutation, which is a form of pontocerebellar hypoplasia, autosomal recessive homozygous mutation, which is likely pathogenic.
Okay. So once we got the gene, and then we have I checked in the literature for the imaging findings. This is a paper again from Eigen on the review of pontocerebral hypoplasia. The imaging findings are not entirely match with the typically described changes. They usually have more extensive volume loss, which leads to subdural collections. Pontocerebral hypoplasia can be again appreciated. Some degree of volume loss also can be seen in the cerebellum. But the main findings or the characteristic findings on imaging with our typical are these extensive volume loss in the supratemporal brain, resulting in subdural collections. They can also have some gliosis in the white matter and pontocerebral hypoplasia. Clinically, these are the typical findings which can be seen: developmental delay, seizures. I think the child also had epilepsy. CSF lactate, and I'm not sure if you had done that, CSF or serum lactate.
No, we have not done CSF.
Okay. So the imaging phenotype is at least the typical ones are extensive or supratemporal atrophy, pontocerebral hypoplasia, subdural collections. They can also have these areas of abnormalities in the periventricular white matter, deep brain nuclei can also be involved, as seen in the typical tRNA type disorders. So imaging, I don't think it entirely matches, but cannot be discounted as what we're thinking of. And then I'll open the case now for panelists.
Well, from my point of view, I agree with all the MRI findings as Nihaal described. I tend to be careful with saying that there is atrophy, but in this case, because it's gray matter structures, instead of just saying sulcal prominence, and to be careful with hypoplasia versus atrophy. But here, clearly, there is a process that is affecting the gray matter, both supra and infratentorial. The pattern is relatively non-specific, but that's what PCH type 6 is, and the associated supratentorial findings tend to be just as prominent as the cerebellar and brainstem atrophy that can be very mild. But the phenotype on MRI is of a neurodegenerative process that affects mildly at this point, insidiously, the supra and infratentorial brain. I've heard perhaps the doctor presenting mentioning that one of the siblings had NCL.
Yeah, so I have the sibling, and the siblings findings are pretty typical of an NCL. This was in 2016, again, supratentorial and infratentorial neurodegeneration with these confluent white matter abnormalities in the periventricular deep white matter, also in the internal capsules. You can appreciate that thalamus are reduced in volume, have these hypointense changes. So these fit with, I think, NCL on the imaging itself. Would you agree, Bruno?
Yeah,
Yeah.
I agree.
I think the main challenge was the first child. We became symptomatic pretty early, and it took almost 2 years to get the genetic diagnosis. By the time we had the genetic diagnosis, the younger child was around 2.5 years. And the parents wanted to test the younger child because by the time we started having 2 febrile seizures. So we did only Sanger for the parent for carrier screening and for the other child as well. And he was a carrier for the NCL gene. So we reassured the family, and meanwhile, the first child died of a progressive neurologic, this one due to NCL. And then this child started having sort of progressive, sort of frequent myoclonus and focal seizures as well, and a lot of tremors, postural tremors, intentional tremors, which were quite extensive. So that's when, because it was not going away and seizures were also increasing, we thought we'll do a whole exome sequencing on this child as well. And that picked up the RARS2 mutation, and is only a carrier for the NCL mutation, which the elder sibling had. Now, this throws up a question. This is a highly consanguineous family. So if we had an antenatal situation like this, like the first child is NCL, and you only do a Sanger sort of testing for that gene only, you might be caught up with this kind of dual gene variant in a highly consanguineous family. So that is where how to go about these things is a challenge. I think both Is the Dr. Sara is also there in the meeting?
No, Dr. Sarah.
No, sir. Actually, ma'am is on the way. She could not join.
Okay. Yeah. Okay. Sure. So that is why, were there any handles when they looked at the data on the first child for the RARS2 mutation, which was not called out earlier, they could find a homozygous mutation even in this first child who died. So we are not sure now whether that child also had RARS2.
Can I comment or question?
Yes.
I mean,
Please, Prof.
The sibling situation is very clear, clinically,
Yeah.
EEG, and the MRI. The
Yeah.
Indian patient here, if I would not know the RARS variant, I'm
Yeah.
not sure whether I was positively point to that. RARS PCH6 can have normal pons, but the few cases I've seen personally or in literature, this cerebellum is very well preserved. I mean, it's a very modest change. There are RARS variants they reported in the literature with even normal imaging presenting as early onset epileptic encephalopathy. So the question is really, are we absolutely sure that this variant is responsible for this child's condition?
Yeah, the variant, the quality of variant is good.
Please close the door.
The quality of variant is good, and it's a likely pathogenic event.
But at times you see patients where you have a pathogenic variant. Also, I think we have discussed in this group, and it just does not fit at all with the clinical overall context. So to have a pathogenic variant is good, but it's not an absolute proof. There are many genetic incidentalomas. Just a general comment.
Yeah, definitely that's a challenge. What we find, especially if it has been an antenatal counseling kind of thing, it would have been even more a problematic thing. But these are the challenges when there is a partial match clinically, that the child has myoclonus, child had atrophy, both supratentorial, infratentorial atrophy. So whether to go for like a skin biopsy in the index child to have one more level of diagnosis, or if whenever the enzyme assays are available. Maybe I think we should do that and then only do the antenatal counseling probably.
I think, Debangna, do you have a reanalysis of the gene?
Actually, we had done a reanalysis at this in 23 this year, and
Okay.
this showed only the child had RARS2, which is pathogenic variant.
Yeah. Okay. But as as Balthazar Aydin has mentioned, that the imaging findings at least do not match or not typical. So rely on the clinical handle if that's more appropriate. Okay, I don't think we
Thank
have
you.
Dr. Sara. So yeah, we'll move on to next case. Thank you. Apurva, over to you.
Yes, sir. So this is a 4-year-old male child who came to us at 3 years of age, where he initially had speech delay. He was following us. After that, he had a history of fall followed by loss of consciousness. Because of this episode, he underwent a CT brain. That time, the CT brain was suggestive of hyperdense area in the inner table of the skull vault and a left subdural collection. During that period, the child underwent surgical intervention, left frontal and parietal burr hole surgery, and evacuation of the infected subdural hematoma. This time, the child was investigated for immunodeficiency, where TLC was normal, lymphocytic counts were normal, CRP was normal, raised ESR was there, and primary PID screening was done for this child. T lymphocyte subsets, NBT test, complement assays, immunoglobulin levels, all of this was normal. The child symptomatically improved on antibiotics, and then for 1 year, the child was asymptomatic.
Okay, at that time, did you have any diagnosis for the subdural collections on the infection, CSF? Or...
No, so we had
Cultures didn't grow anything at that time.
Okay.
Then the child in between past 6 months had history of juvenile plantar dermatitis, and 2 episodes of pneumonia requiring antibiotic and hospital admission. Again, after 1 year, the child presented to us with complaints of only speech regression and not being able to walk for 1 week. So we got an emergency CT done, and that time the CT was normal. Other lab parameters, blood investigations were also normal, and there was no fever. But over a span of 1 month, the child became more dull, and there was further regression in his motor abilities. Then we again investigated the child, and that time the CT brain was repeated, and MRI was done. So
Yeah, you had something else to say?
So this time the child was investigated again, and then MRI findings. Nihaal sir would.
I think while waiting for Nihaal, this child had extensive skin lesions. Always he had a lot of skin lesions. So that's why, and having that kind of failure to thrive, skin infections and subdural. So at the initial evaluation, we did all the in this one immunodeficiency workup, primary immunodeficiency workup, sparing the genetics.
While Nihaal comes back, he sent me just a few hours ago the preview of the slides. So maybe I can just show the images briefly.
Yeah, sure. Thank you.
I'm going to discuss somewhat real time, but you can see here a non-contrast CT image from May 2023 showed some mild generalized prominence of the sulci and ventricles, so there's probably some mild cerebral atrophy. And here is this density between the cortex and the calvarium is the subdural extraaxial collection that was reportedly drained. And it was thought to be infected, correct?
Yeah, it was infected.
And here's the MRI. This is diffusion weighted imaging on the top, and it shows perhaps there is some abnormal signal intensity either to the calvarium, or there's a very small extraaxial collection surrounding the brain at the top of the convexity. I believe this is probably the marrow signal on diffusion, that the bone marrow is abnormal diffusely because of a systemic condition. Then there is some artifact near the skull base, but there's a lesion in the inferior temporal lobe that we can see on the FLAIR images. FLAIR images repeat the findings on the CT with atrophy, extraaxial collection, but there is also a focal heterogeneous T2 hyperintense lesion in the inferior temporal lobe, surrounded by a T2 hyperintense signal that spares the cortex. So this is all vasogenic edema, most likely reactive to the presence of this lesion. Ignore the signal in the ventricle. This is just CSF flow artifact in the fourth ventricle. There are gradient echo or susceptibility weighted images for blood, and they're showing part of that extraaxial collection as these dark foci, some scattered blood products that are indeterminate age, probably chronic, including in the wall of the atrium of the right lateral ventricle. And then that lesion is showing susceptibility signal from probably blood products. And notice on the T2 weighted images that it seems to have a capsule, which is intermediate in signal intensity, and contents that are T2 bright and also T2 hypointense and heterogeneous. So most likely blood products, But whenever we see a lesion intraaxial that is also T2 hypointense, we should think of granulomatous and fungal infection as well. Other things that could cause inflammatory lesions with T2 dark signal would be histiocytic lesions, perhaps even fibrous, which would be more common, or sarcoid in the granulomatous, but that would be more extraaxial. So here, because it's intraaxial, has a capsule, I'd love to see the contrast. Let me see if the next slide has, yeah, there's contrast. So here's T2, T1 pre-contrast, showing some of the T1 hyperintense blood products. And this is T1 post-contrast, very heterogeneous lesion with some areas of central fluid or necrosis. It's not entirely solid. And given the appearance of T2 being more like a fluid collection, you would think that this is some sort of abscess, but not pyogenic, given the lack of centrally diffusion restriction, but more on the granulomatous or fungal abscess in a child that already had a infection in the brain. I think these were all the images, and you could continue with the clinical discussion for now.
After this imaging, the child underwent surgery where we took the biopsy from the lesion, and that biopsy sample, it had pus also from the abscess cavity, and that was sent for histopathological examination and routine microscopy. In the routine microscopic examination, there was branching fungal hyphae growth, and that is when the child was started on dual antifungal therapy, amphotericin B and voriconazole. It is the third week after this biopsy was done, sample was sent. Till now, there has been no fungal growth as of now. But the child is clinically improving. There has been no further fever spikes or any other deterioration. Overall, the sensorium and cognition is better. Since the child had such severe second episode of intracranial brain abscess, likely fungal, we sent the whole exome sequencing, and the whole exome sequencing report came, which is suggestive of C1q deficiency, complement pathway deficiency, which has led to such recurrent skin infections with pneumonia and twice one brain abscess infection.
Thank you. I believe Nihaal is back. There you go.
Yeah, I'm sorry for that. I just had some technical issues. Yeah, so I think before you can probably take over from here. Can you see my screen?
Yes,
Yeah.
sir. So we sent all these panels initially that I discussed, all the screening PID panels, but we realized that there are a lot of primary immunodeficiencies which may not be picked up on the primary screening of the PIDs. That is where whole exome sequencing is important. If there is a strong handle in clinical history, gene expert of that sample for tuberculosis was negative, and the pus culture showed branching fungal hyphae as discussed. And beta-galactomannan assay was sent, which is high, 1.8, cutoff is less than 0.5. So that is also suggestive of a fungal infection. Next slide. So next slide. This C1q deficiency, the report of whole exome sequencing, which is a pathogenic variant, has come for this child.
All right. But they are mostly known to cause Streptococcus and Haemophilus, is that right? At least that's what I got on the literature.
Yes, sir.
And SLE-like presentation.
SLE-like presentation is commonly associated.
Yeah. Okay, if anyone has similar experiences with this scene and for the imaging presentation or the clinical presentation.
There's one extensive review of around 45 patients as a survey. And what they have noted is most of them have very early onset SLE-like presentation, but a percentage of them have overlap of infection plus SLE, and some of them have just recurrent infections. So this child currently has some skin markers the SLE, like he has photosensitivity and the skin lesions, but we are evaluating for that. And meanwhile, he has currently only manifestations of infection, recurrent infections. So a small percentage with C1qa deficiency can have only infections, recurrent infections as their primary manifestation.
It was remarkable that the imaging also shows some mild generalized atrophy of the brain.
Yeah, Dr. Suarez, yeah. So yeah, generalized atrophy.
I have no experience with immunodeficiency syndromes on the long run. Is there a comment about the long-term management? Will he get prophylactic treatment?
Yeah, actually, they actually benefit from fresh frozen plasma, which gives some monocytes, and they do well. There are 3 incidents of stem cell transplantation, sort of bone marrow transplantation, which have been tried. 2 of them have improved well, and 1 died. So still, we're not sure whether stem cell bone marrow transplantation is going to help this child.
Thank you.
Thank you.
Thank you. Prituja, over to you.
Good evening, everyone. We have a 6-year-old female child who presented to us with history of headache, blurring of vision, double vision for 3 days, and she also complained of photophobia 1 day prior to presentation. She had no significant past history. Birth history was not significant, and she was a developmentally normal child. On presentation to us, the significant finding that we found was she had upward gaze restriction with no neurological deficits that was present at the time of examination.
Okay, so only visual abnormalities and headache, but
Yes.
headache was not acute.
No, yes, sir. It was since last
Okay.
3 days she was having.
Okay.
She
So
had
headache and
gaze abnormalities as well, examination.
And then
no encephalopathy.
no encephalopathy.
Okay. And then the MRI into day of illness. Which day of illness? Any idea?
This was on the 3rd day of illness.
Okay, so again, you have multifocal fluffy hyperintensities, predominantly involving the white matter structures, periventricular white matter, deep white matter, some juxtacortical or subcortical regions over there in the frontal lobes, also involving the corpus callosum. You can appreciate the periventricular hyperintensities over here, and again, the peritrigonal or posterior periventricular occipital regions. So multifocal areas of slightly heterogeneous T2 hyperintensities. The central areas are more T2 hyperintense as comparison to the peripheral areas. That will be better demonstrated on the flare sequences. And coming posteriorly, you have this area over there along the left middle cerebral peduncle, left cerebellar white matter. So multifocal abnormalities involving predominantly the white matter structures. The deep brain nuclei over here at least are spared in terms of the signal abnormalities, and also the brainstem did not demonstrate any signal changes. In terms of volume, I think this brain is okay for the age. There's no significant atrophic changes in the cortical regions. On the flare sequences, we can appreciate the similar changes on the T2 weighted sequences. Again, multifocal abnormalities predominantly involving the white matter structures, periventricular, deep white matter, also the peripheral regions of the brain. On the sagittal sequences, you can appreciate the orientation over there. Again, deep white matter structures, periventricular white matter structures are predominantly involved. And posteriorly, this focal lesion in the left cerebellar white matter. And possibly over here, there was some patchy abnormality along the dorsal aspect of the pons going into the middle cerebellar peduncle. On the diffusion weighted sequences, most of them demonstrated some areas of restricted diffusion, as you can see over there on the DWI sequences. Some had the T2 shine through, whereas some had the true restricted diffusion, as you can see in the corresponding low signal changes in the superficial white matter structures, the deep white matter structures, the periventricular regions along the occipital horn, and also the cerebellar abnormality had these peripheral areas of low signal changes on the ADC sequences. Post contrast, the lesions demonstrated nodular, some had incomplete ring-like enhancement, some had targetoid type pattern of enhancement. So mixed pattern, the nodular, targetoid, and incomplete rim-like enhancement demonstrated in the region. And on the optic nerves, you can appreciate on the coronal and the axial sequences, bilateral optic nerves demonstrate optic neuritis from the proximal to the mid segments. The retrobulbar segments are relatively spared. Again, the coronal, you can appreciate there are some areas of perineuritis or optic neuritis over there on both sides. The spinal cord was screened and could not appreciate any lesions in the spinal cord. No contrast was done. And the differential which we thought of was a demyelinating disorder. The child was not encephalopathic, so possibly a clinical isolated syndrome related to ADEM oligoclonal glands can also demonstrate these changes in the targetoid type appearance on imaging itself. Then we thought of a companion case, which was discussed previously, of a Behçet syndrome. I don't think the child has any lesions over here, but this was almost similar type of appearance, multifocal lesions, which had targetoid type appearance of contrast enhancement. Some had the nodular enhancement pattern, but this child had additional skin and genital ulcer. The demyelination in terms of optic nerve involvement. These are the patterns of optic neuritis in the demyelinating disorders. NMO has more of a mid and distal involvement. The MOG antibodies have the most proximal and mid involvement. ADEM can have bilateral extensive involvement of the optic nerves, whereas multiple sclerosis usually has a unilateral type appearance. This is our case, which had bilateral proximal mid segments, almost going up to the entire segments of the optic nerve on both sides. And then the follow-up, Prithija.
During the hospital stay, we did the CSF analysis, which showed, which is essentially normal. CSF viral PCR was negative. In view of demyelinating disorder, we sent for serum NMO, MOG, and NMO and MOG, and which was negative. We sent for oligoclonal bands, that was also negative. And in view of neurosarcoidosis, as cranial nerve pathology was the most important history in this one. So serum AC levels were sent, that was also normal. Visual evoke potential showed prolonged P100 latencies more in the right than on the left eye. So
clinically, you're thinking only optic neuritis and demyelination, or any other studies? No other clinical handles, I think, to help us out.
Not up now. So this.
Oh, okay. Yeah, I'll open the case for panelists.
Yeah, she improved quite well with the steroids, and after follow-up, her eye movement abnormalities are all almost normalized. Some gait issues which were there are also normalized on follow-up.
I would just add that this case has all the classic features of ADEM at presentation, and we know that ADEM doesn't really mean the etiology of the lesions. The workup looks like it was very complete, and the major diagnosis radiographically would be MOGAD, particularly given the distribution with the larger lesions supratentorially and the involvement of the middle cerebellar peduncle.
Thank you. Thank you, Bruno.
I just wonder if we need to repeat MOGAD or MOG antibody in the future to make sure it doesn't fluctuate and may turn out to be increased. With our current knowledge, this is highly suspicious for ADM related to MOGAD, and the MOG could predict a recurrent course.
Yeah, I think we are planning to repeat the MRI in 3 months' time. And after that, maybe SS do the repeat MOG antibodies at the same time. Thank you.
Thank you. Nihaal, did you have trouble with the next case? I can try to share again. I'll start showing just the history on the next case if you guys prefer.
Sure. Yeah. Please go ahead, Bruno.
Let's see. These were the slides that we just saw. Okay, so that's the next one, and I'll wait for Nihaal to take over. Please, the clinical presenters.
Yeah.
Prithija.
This is an 11 years old male child, was developmentally normal, and in last
11 months or 11 years?
11 months, sir. 11 months. 11 months, developmentally normal. He had vomiting multiple episodes on 4th of June. The next day, he developed low-grade fever, which was there for less than 24 hours. And the following day, he developed multiple episodes of loose stool. He was in between, he was fine for next 72 hours. And on the third day of loose stool, mother noticed in the evening that he had multiple episodes of left focal clonic motor seizures with impaired awareness. For which the child was initially admitted in a tertiary case in a district hospital and then referred to a tertiary care center the next day morning. So he was so MRI was done. So this MRI was done into day of illness 3 to 4 of neurological manifestation.
All right, so here's the MRI. We're looking at diffusion weighted images, one ADC map from the diffusion weighted imaging, one susceptibility weighted image, and one flare image, all in the axial plane. So the most remarkable finding, the child has a normal brain volume. There is bright diffusion signal in the whole of the basal ganglia. So you can see the putamen, the caudate, the globus pallidus. And here I suspect that we're just catching the body and then the tail of the caudate. It's highly symmetrical. It's sparing the internal capsule and the thalamus. And it has corresponding dark signal on the ADC, dark or low values, indicating it's truly diffusion restriction, no blood products or mineralization, and very mild, if any, flare signal in the dorsal putamen, indicating that this is acute injury that hasn't yet caused any atrophy or gliosis. In fact, I think you would agree that the basal ganglia looks swollen. Here is T2 weighted imaging, and this child is 11 months, you said. So we see myelination of the central structures like the corpus callosum and incomplete myelination of the more peripheral structures. Here is the optic radiation. So I think that's appropriate level of myelination for an 11-month-old. The posterior limb of the internal capsule is okay. And here again, very mild T2 hyperintense signal and some swelling of the basal ganglia. There are also some cuts through the posterior fossa, which brainstem and cerebellum look normal. Let me see if there are more MRI images. Oh, this is July 2023. So this is a follow-up showing that there has been interval progression of now atrophy involving the basal ganglia that were affected. You can see, for example, on flare images, globus pallidus, putamen, and caudate have all lost volume. And it remains very selective injury to these regions, although one may question if there is now mild generalized cerebral atrophy. Diffusion weighted image is now negative. I'm discounting if there is maybe some minimal signal here in the subthalamic nucleus. The posterior fossa remains negative. And here on this image in the midline, we see mild thinning, but otherwise normally myelinated corpus callosum, normal cerebellar vermis, and normal brainstem. Let me look at this spectroscopy for a second. So was done in deep brain structures on the right side. Here, this is probably intermediate echo because we're seeing a very mild negative doublet of lactate, probably within normal limits, maybe slightly increased. Otherwise, choline, creatine, NAA with very mild, child is 11 months, so perhaps just mildly decreased NAA relative to choline, and NAA would be a marker of neuronal density. So it just, and neuronal maturity and viability. It indicates that there is some injury to the brain, but quite non-specific. There's also at about 2.3, 2.4, a peak that we also see in the white matter. This may be perhaps glutamine, unless it's a very specific peak of a enzymatic deficiency. And otherwise the pattern in the, oh, maybe Nihaal is back. Otherwise the pattern in the white matter is relatively the same. He just said he's having some issues with the connection. Oh, let's see what else is here.
Oh, sorry, I'm back. Yeah, but yeah, you can.
Yeah, do you guys want to take over from here?
Yeah. Just
So,
right. Yeah. You'll have to stop sharing.
Stop sharing. Okay, let me do it. What's that, Nihaal? Oh, good.
Oh, is this the case we're on? 4?
Yes, Nihaal, I showed
Yeah.
all the imaging findings, the symmetric
right.
injury to the basal ganglia, the follow-up,
Yeah.
normal background myelination, and now we're about to discuss the differential diagnosis for this very
Got it.
symmetric appearance. Yeah. And the spectroscopy, I thought it was relatively non-specific,
Yeah.
with some decrease in AA.
Yeah. Yeah. So this is what I don't think have they covered this. TMS and the whole genome was negative. Then based on the imaging pattern, we thought of these possibilities. Glutaric aciduria is the only one in terms of the basal ganglia involvement. The more confluent abnormality which you thought of was similar to our case, but the typical appearance of frontotemporal atrophy, subdural collection was not present in our case. Propionic acidemia, mitochondrial disorders, biotin thymine, they predominantly have a dorsal striatal involvement and a more patchy kind of involvement or more inhomogeneous type involvement with some cystic degeneration or necrosis. Not always, but typically seen. As seen in these examples, the globus pallidus is relatively spared. Then we thought of, we reviewed a paper which was recently published. And again, the cluster 1 abnormalities, they described them with the mitochondrial disorders, biotin thymine related disorders. And then further, because the genomic was negative and the TMS also was did not reveal any abnormalities, we thought of a possible autoimmune, but the child was relatively young for an autoimmune antibody-related disorder. This imaging pattern over here of the anti-dopamine 2 receptor had similar initial changes of the basal ganglia. And on follow-up, I think this was after 6 weeks, the changes were reduced. The other autoimmune conditions are the CV2 and MDR, which were again negative in our child, and the child is possibly too early for these antibodies. We're still, I think, considering a possibility of a genetic over autoimmune, given the extensive involvement of the deep brain nuclear structures and was very symmetrical in nature with these diffusion changes. This is what we thought of, and I think the whole exome sequencing has been sent, but we'll appreciate any inputs from the panelists and others for this.
Yeah, just a small correction. The mitochondrial genome sequencing, we had the results. Whole exome, we are awaiting the results as it. Extensive urine organic acids and the TMS and all the other panels were negative. And very extensive virology panel was also done. All the things were negative, except I think mumps, IgG and IgM were positive. On follow-up, the child still is quite dystonic, but slowly improving. partial neck control and some truncal dystonia and limb dystonia is persisted still, but cognition is much better.
And was there any lactic acidosis or increased lactate in the CSF?
I don't think so.
No.
No.
Devangana?
CSF lactate was 14.7, slightly on the higher side.
Okay.
Did the child have a big head? Typically in glutaric aciduria, children can have a big head.
Head size was normal.
Was normal, normal.
47.5 centimeters.
But on the SAG, Dr. Soares, do you agree? It appears slightly bigger.
Yeah, it does. It does. Yeah.
And also what I thought was on the initial scan, the left sylvian fissure was slightly widened. Temporal lobe sulcation over there is whether it is underoperculized or not. And it's a milder spectrum of the glutaric aciduria was a doubtful question here.
Nihaal, I just had a case exactly like that with selective injury to the basal ganglia, and only one side had the opercular hypoplasia or sometimes a cystic appearance of under-opercularization. And I discussed with Dr. Hisham Damush, my colleague, has vast experience with neurometabolic disorders. And he showed me a collection of glutaric aciduria, and not a single one of them, this pattern of under-opercularization is unilateral.
Okay. Got it.
I still mention it in my report just to make sure that it gets investigated.
Yeah. The only thing or possibility was whether the child is a low excreter, whether when the TMS was done. If I'm not mistaken, the glutaric aciduria, the enzymes get excreted only during, they're more higher during the metabolic crisis. So whether the sample was done at the stage of crisis or not, that's a question.
Only if they are low excreters, then you can miss out. But this was done during the acute period itself.
Okay.
It should have some telltale evidence at least when they've done all the things during the acute period.
Got it.
But the genetics generally should pick up most of the abnormalities.
Just to underline what you just said, low excreters have a prevalence in Germany of about 3%, and these patients are missed on neonatal newborn screening.
Yeah, got it, Eugen. But this was done, I think, at the time of crisis, is what Dr. Lopez was mentioning.
It's just a general comment.
Got it.
I'm not arguing about the diagnosis here.
So just to summarize, we're still thinking genetic rather than infective or autoimmune or immune related.
We are looking at a possible genetic etiology.
Okay.
But we have had one or two children similarly, just this kind of pattern, all that investigations negative, including genetics. And 2 of the 4 have improved very well. They have come back to their normal. And 2 of them have issues long-term, even after a few years. So we do not know what will be a good handle in this kind of situation.
All right, Devangana, maybe you'll get back to us with the whole exome result if any gene is picked up.
Yeah, maybe by the next meeting we have the whole exam report.
Sure. Thanks. Dr. Vivek, over to you.
This is a 2-year-old boy who, at present, his issue is more due to his arthrogyposis, distal arthrogyposis, which is due to a neuropathic process. Exome is planned, still to be sent, but at birth he had poor respiratory efforts, probably because his neuromuscular problem, ventilated, had low sugars as well initially, easily controlled. It was more the MRI which was done in the neonatal period to discuss, which has some changes which I was not clear about what could be the reason. Even though now he doesn't have any motor issues, motor issues related to a central cause. So it's all peripheral neuropathic process with a normal cognition. and more of open mouth, drooling, retinographia. So this video. So he's a sharp boy, but his arthrogryposis and the facies suggests a neuromuscular process.
Got it. So
Has he still contractures at this age?
Yeah. He has got arthrogryposis.
Yeah, but this is just a label.
Right. So there he is. The contractures.
any infection or fever, febrile illness during the neonatal period, Dr. Vivek?
No, it was all a perinatal issue.
Okay.
Perinatal in the sense event respiratory issue, and then ventilated, and then hypoglycemia in first few days.
All right. Okay, so I don't have the exact date, but this is a neonatal scan. And on the T2-weighted sequences, you can appreciate, especially in the left parietal lobe, it is slightly more hyperintense in comparison to the contralateral side. The cortex, you cannot really appreciate the cortex. It's possibly edematous over there. Maybe some volume reduction will be better evaluated on the T1 or the FLAIR sequences. But if you see in general, the left parietal lobe is slightly more hyperintense. There are some punctate foci of T2 hypointensities in the centrum semiovale. Again, coming down in the deep white matter, you can see these focal hypointensities. These are likely hemorrhagic foci. Inferiorly are coming more. Then you can see again in the perisylvian region, these are these T2 hypointense areas. And again, you see that the left posterior temporal and occipital regions has a more slightly attenuated hyperintense signal changes in comparison to the contralateral side. The caudothalamic groove on the right side is again demonstrate this focal hypointensity. I could not appreciate any abnormalities in these dural sinuses in terms of thrombosis. They're slightly prominent, or the bilateral transverse sinuses over there. And sigmoid sinus, again, the phlovoids are patent, but they are slightly prominent in comparison to what we see normally. On the FLAIR sequences, you have these again, the left parietal cortex and subcortical white matter as demonstrated as edematous changes. The cortex is hyperintense over there. And also the frontal lobes possibly demonstrating some areas of edema, though it's an unmyelinated brain. But the left parietal lobe and the temporal and occipital lobe is abnormal. Also you see the perisylvian regions on both sides demonstrate these FLAIR hyperintensities with these hypointensities in the subcortical white matter. On the diffusion weighted sequences, again, there is area of restricted diffusion in the left hemisphere, the cingulate gyrus over there, the parietal lobes over there, and also in the perisylvian region. And there is periventricular area of restricted diffusion in the peritrigonal regions over there, some areas in the internal capsule on both sides. This is a T1 FLAIR non-contrast. And again, you see that there are similar changes what we've seen on the FLAIR sequences. This is not a contrast sequence, so these hyperintensities are again suggestive of hemorrhagic foci, likely hemorrhagic foci, which we have seen on the T2-weighted sequences. Caudothalamic groove also has this hemorrhagic foci, and some area of cortical lamina necrosis over there possibly, and edematous changes in the temporal lobe, parietal occipital lobes. On the sagittal sequence, you can see that the lining of the brainstem has these hypointensities, again, suggestive of likely hemosiderin deposits. There is some hypoplasia of the vermis, and the tegmentovermin angle is is markedly widened, not typically fitting into a Dandy Walker spectrum, but possibly a smaller variant with inferior hypoplasia, vermin hypoplasia. Yeah, and that's, I don't have a contrast sequence. These are just changes, and I thought maybe these are related to an infective process going on there and possibly related to the hypoglycemia. The hemorrhagic abnormalities, I wanted to know if there was any sepsis or any hematological or coagulation disorders which might have caused these microhemorrhages within the brain. But Dr. Vivek, I think you mentioned that there are no septic markers or hematological abnormalities.
No.
Okay, got it. Yeah, I'll open the case now for further comments.
Any correlation with the arthrogryposis? Doesn't look like this, more of a acute event in the neonatal period.
I think there are more muscular disorders or myopathic disorders, which the imaging I don't think fits. As you say, more acute neonatal related changes is what I think of. So, yeah. So to summarize, or I can note location. Anyone wants to come in? Yeah.
Can you show the sagittal images again? It's not the solution of this case, but the tegmentovermian angle and the fastigial angle are far beyond any normal values. So from the phenotypic appearance, this is Dandy Walker, not variant, but Dandy Walker. And just a detail, if you look at the hypophysis is enlarged, which is an occasional finding in neonates due to the hormonal situation. It's not unusual.
But they also carry the maternal hormones. Is that right? Sometimes the hypophysis. Okay. I couldn't find.
No, this is a normal neonatal
Got it. Yeah.
hypophysis. You can see the same in puberty, that you have a kind of a due to hormonal situation, you have an increased volume of the hypophysis. It has no particular meaning.
Yeah, got it.
We may learn something from repeating the MR.
Sure.
I think we might find medial gliosis or chronic changes, but not related to the arthrogryposis.
Right. So it's so unilateral. That's the thing. More unilateral.
More unilateral, but yeah, you can see that on the right side there were changes. Yeah.
Can we be sure from this image that there wasn't a superior sagittal sinus thrombosis?
That was the query I had, but maybe it's not.
We didn't do an MRV, but yeah, I can see the at least the T2s, at least up till here, I could see the flow wides. I don't know if over there, over here.
Yeah, looking right now, I just think it's somewhat indeterminate. It's probably just the flow voids, but you have to be comfortable with the way you acquire the sequences, because a clot can be just T2 hypointense, usually a little gray or intermediate signal. But for example, these T1 images, they don't give you confirmation one way or the other.
Yeah, I agree.
The pattern of injury is not consistent with only durovenous sinus thrombosis. It goes too lateral into the parietal lobes, and there are all these hemorrhages. But this could be infectious for sure. It's also not a distribution of arterial ischemia. The pattern of the Dandy Walker phenotype is probably congenital, but we also have to think if there was a process causing abnormal development or CSF reabsorption because of all these hemosiderin in the cerebellar fissures. Dr. Boltzhauser, don't you think that the inferior vermis, if you separate the vermis in three major parts, the inferior one is very small, and it looks like there's some mass effect from the cystic enlargement of the posterior fossa?
Mass effect in what sense? I'm not sure whether I understand your argument.
In the sense that at some point, and perhaps it's just a developmental finding, the enlargement of the posterior fossa cystic abnormality has prevented the normal development of the inferior part of the vermis.
I have no definite answer.
Okay.
So Dr. Vivek, just to summarize, we are looking at an acute event. Thrombosis cannot be ruled out because the venography wasn't done, but I don't think the changes are related to the clinical condition of the patient now.
Okay.
Yep. Thank you.
Yeah.
Sorry, Aryan, are you there? Sorry, I put it as
Yes, sir.
Sorry, go
yes,
ahead.
sir. So our patient 6-year-old male child a case of short stature was referred from endocrine OPD with complaints of frequent falls. On examination, the patient had the old man look with high temporal balding, and cerebellar signs were present on examination. He was extensively evaluated for short stature, and all the baseline workup, including growth hormone stimulation test, thyroid function test, came out to be normal. We did 2D echo and USG abdomen pelvis, that also came out to be normal, and we went ahead with the MRI. He also had history of photosensitive rash when he was around 2 years of age.
Clinically, you would have thought of DNA repair disorders?
Sir, pardon, sir?
Clinically, you would have thought of DNA repair disorder?
Sir, actually, with the history with this old man look and with the history of photosensitive rash, even though seizures were not present, we suspected cocaine syndrome.
Yeah, exactly. The DNA repair. This is a part of group of DNA repair disorders.
Yes, sir.
Yeah. Okay, sure. Thank you.
All right. So MRI done at the age of 6 years, and you can appreciate on the T2-weighted sequences homogeneous hyperintensities in the cerebral white matter, a hypermyelinating type of pattern, appearance in the bilateral cerebral hemispheres. The corpus callosum was relatively spared over there in terms of the myelination abnormality. And if you see on the T2-weighted sequence in the globus pallidus and the ventrolateral thalamus, it is hypointense, abnormally hypointense for a 6-year-old. Coming down supratentorially, there's no volume loss in terms of the cortical regions or the deep gray nuclei. Posteriorly, cerebral peduncles are slightly hypointense, but yeah, we probably need a SWI to confirm that. And again, some tracks, the dorsal brainstem is again slightly hyperintense for a 6-year-old, so some myelination delay or hypomyelination type pattern over there. Similar changes on the flare sequences, and you can again appreciate the hypointensities in the cerebral peduncles and the globus pallidus. These are the SW sequences. I'm not sure of the slice thickness, but again, you can appreciate that the globus pallidus is slightly dark, and also the cerebral peduncles are demonstrating this focal blooming on the SWI or GRE sequences. On the sagittal sequence, I could not appreciate any cerebellar atrophy. The corpus callosum is slightly thin in the segment, the mid and posterior segments, and there was no cerebellar or cerebral atrophy, which again you can see on the coronal sequences. The sulcal pattern and the folial pattern is normal for a 6-year-old. Okay, I'm sorry that there was some formatting issue, but thinking of hypomyelinating patterns with dark deep gray nuclei, and the first image is that of a fucosidosis, hypomyelination with dark globus pallidus. They usually have some cerebellar atrophy. This is gangliosidosis, but our child did not have any hyperintense changes of the dorsal striatum. Pol III-related leukodystrophy can have these hypointense changes in the ventrolateral thalami, the globus pallidus. They usually are associated with cerebellar atrophy as an early finding. Cocaine syndrome can have these mineralization abnormalities in the deep gray nuclei, predominantly in the putamen and also the globus pallidus. Oculodentodigital dysplasia again has these hypomyelinating patterns with dark deep gray nuclei. So these were the differentials which we thought of, and hypomyelinating pattern with these deep gray nuclei changes. I'll open the case for the comments now.
I'll just make a comment on the neuroimaging pattern, Nihaal. There is very mild of this leukoencephalopathy that we can perhaps call hypomyelination. We should notice that all the central structures like the corpus callosum are normal in volume and completely myelinated. So it's not a severe disorder. And then perhaps in the posterior limb of the internal capsule, we can see that it's not as robust as we expect. So we shouldn't, and you correctly already showed, we shouldn't think of that as a profound hypomyelinating disorder, but a disorder that features mild hypomyelination in its phenotype, but it's such a pure neuroimaging phenotype that becomes relatively non-specific. As for the T2 hypointense signal of the globus pallidus and of the substantia nigra, did you have susceptibility to show if this was any iron deposition?
Yeah, so these were the, I think, GRE sequences.
Yeah, it's questionably abnormal. Certainly no T2 hypointense thalami to start thinking of gangliosidosis and some of these other disorders you showed.
And for cocaine, they usually have cerebellar atrophy to as a feature. So whether it is there always or not may be questionable, but
well, it may depend on the phase of the disease, but typically with calcifications, right?
Can I come back to a simple clinical question? First, I may have missed it. Did you look at the bone age in a hand X-ray? Is it appropriate for age or is it delayed? Then always, if you have a patient with a short stature, do you have data about the stature of the parents and any siblings? And third, what are you looking for in the abdomen, in the pelvis, in this context? Any suspicion for what?
So USG we did in the in view of syndromic workup to find any association we can find in.
No, that's an important question actually. See, for any imaging, you need to have a pretest possibility. What are you thinking as a pretest possibility? What are you going to find? Then you ask for it. If you don't have that thinking process, it becomes difficult.
Okay, sir.
And just a note, was the thyroid levels checked?
Yes, sir. Thyroid levels were checked. They were normal.
Okay. Because sometimes they also have some delayed myelination pattern.
Yes. No, sir. It was normal, sir.
Sent for genetics or?
Sir, actually, the patients are not the parents were not affordable.
Okay.
So that's why genetic testing could not be sent, sir.
Okay. Yeah, so we are thinking genetic with myelination abnormalities, but maybe not as typical or profound as seen in cocaines. Maybe it might develop later on.
Okay, sir.
The calcifications and the atrophic changes. But yeah, if the clinical phenotype matches, then.
Okay.
Yeah.
Thank you, sir.
Wait, Dr. Vivek, over to you.
Yeah, so it's one of my colleagues' patient, so he wanted me to discuss it here. So unfortunately, he cannot join, so I'll sort of go through as much as I know. This girl was admitted. She has a background of anxiety disorder for which she's on escitalopram. She had been vaccinated for chickenpox, but developed chickenpox confirmed by a dermatologist without much fever. And after the lesions had started to subside, she became encephalopathic with no seizures. And GCS was really low, for which she had her evaluation. CSF protein was normal. She is now, actually, this was when I wrote, MPS had already been given after the MRI and IVIG had been started. But now she has responded that she is fully conscious, ambulant with help, taking orally. So the response has come over the last 7 days after the initial conventional immunomodulation. First 5 days of methelpid, and then day 3, day 4 IVIG was started. Now 8th, 9th day into illness. So we haven't done her MOG because somehow we thought this is related to her varicella process in some way, if it is. So that's what I want to discuss. These lesions look more confluent than an ADEM like illness. So as people seen it with chickenpox.
Yeah, so yeah, we have the flare axles, and you can appreciate that there are confluent white matter changes, especially in the deep white matter, the superficial white matter on the frontoparietal regions on both sides. Coming more inferiorly, it is more patchy in involvement. You can see that the gray matter is also involved in the frontal lobe over there. The coronal radiator of the central semial veil is involved. The periventricular regions also demonstrate these hyperintensities. Further down, you can see that there are focal lesions in the bilateral basal ganglia. Periventricular regions along the occipital horns have these, again, these hyperintensities, more on the right than on the left. And also the temporal lobe over there, the posterior peristaltic region has these hyperintensities on the flare sequences. Bilateral peritrigonal regions, again, these flare hyperintensities, some subcortical abnormalities over there in the temporal lobes. Coming down to the infratemporal structures, appreciate a focus of hyperintensity in the pons over there. The cerebellar white matter or the peduncle has on the left side the focal lesion, and the medulla also appears slightly bright than normally seen. So supratentorially and infratentorially, they are multifocal, partially confluent in the superficial areas, partially confluent, and multifocal abnormalities as you come further down. With periventricular, the white matter involvement, the deep gray matter involvement, subcortical, and also gray matter structures were demonstrating these multifocal abnormalities. Similar changes on the T2-weighted sequences, what we've seen on the flares. None of them had any hemorrhagic or calcific foci within them. On the diffusion-weighted sequences, I could not appreciate any areas of abnormal restricted diffusion. A T2 SAG wasn't done, or we have T1 SAG, and again, I could not appreciate any changes in terms of volume loss or focal abnormalities. The optic nerves, they appeared to be of normal signal on both sides, so could not appreciate any optic neuritis or edematous changes, at least on the non-contrast sequences. But post-contrast here, none of the lesions demonstrate any abnormal enhancement or significant enhancement. But the optic nerves on the fat side sequences, especially the right side over there, is demonstrating these some kind of optic neuritis. Better again appreciate on the coronal sequences. You can see that the right optic nerve is slightly more edematous or demonstrating these contrast changes in comparison to the left. So I would say possibly unilateral optic neuritis over there with these multifocal abnormalities involving gray and white matter structures. And then we're again thinking of the typical classical patterns of demyelination disorders. I would think of NMO, which has a more central appearance, but the optic nerve involvement is slightly atypical. Multiple sclerosis can have focal abnormalities and multifocal abnormalities with the unilateral optic nerve involvement. So demyelinating spectrum disorders are the initial, at least the initial possibility on the imaging, the MRI we have. HLH was raised as a possibility. The changes are more extensive, more cerebellar involvement, these more punctate or areas of enhancement, and some hemorrhagic foci typically seen in HLH, which are not seen in our case. Regarding varicella, I have not seen such an extensive involvement of varicella related infection, especially the white matter changes. There, as far as I know, there are more, demonstrate more ischemic changes, small vessel ischemic changes, and cortical changes. So demyelination, parainfectious demyelination is the imaging possibility you're thinking of. And now I'll open the case for further comments.
It's perfect from an imaging standpoint, and that it does have some fluffy, larger supratentorial lesions and involvement of the white matter of the cerebellum near the middle cerebellar peduncle. Yep. So parainfections in the sense that the viral infection may have been a trigger. And we should still keep number one here as MOG.
And the response to steroids also is possibly a pointer towards.
It was more response to IVIG, steroids, but maybe we gave the two things back to back, so difficult to know. But MOG does respond well to IVIG. Often you have to give monthly IVIG to prevent the relapses.
Would you also check for oligonucleotide bands, Dr. Vivek?
Yes. Now after the discussion, ideally we should. Yeah. If we have CSF, we'll send it.
Got it.
I don't know if people can tell me if the CSF, how old is oligonucleotide bands, how reliable it is to send. Is it like if you send it after 5-7 days, it's IgG index. So whether one can send it up to 3 weeks if it is preserved. I don't know the answer because it's difficult to repeat a lumbar puncture often for this only. So if anybody else had a take on that. Can we send CSF oligoclonal bands after maybe sort of 7-10 days? If IgG half-life is 21 days, so can one do it for up to 2-3 weeks? if it is a sample stored. So I'll find out.
Yeah, that asked us to the end maybe.
Right.
All right, thanks. Yeah, Geetika, are you there?
Yes, sir. Yes, sir.
All right.
Yeah.
Okay, go ahead.
Yes, sir. On behalf of Geetika, Dr. Reddy. So,
Yeah.
sir, we have a child, 2-year-old child. The parents brought the child with one episode of uprolling of eyes for a brief period, followed by head drop. And upon examination, by the time we admitted the child regained consciousness. So we thought like a seizure episode for a brief period. And on examination, we found the child is having a significant motor delay as well as speech delay, corresponding to motor corresponding to 6 to 8 months of age. Is just holding the head, and it's trying to when the pull to sit, is just with support she's able to sit. And speech hardly she's saying monosyllables, and she had a third-degree consanguineous. Physical examination reveals a severe microcephaly. Otherwise, cognition, mother able to recognize the mother and father. She's responding appropriately with the verbal and non-verbal commands also. So that's it, sir. We have otherwise third-degree consanguineous is the one thing from the family history, and other siblings are fine. This is the second in birth order.
Okay. Yeah, got it. Right. At what age was MRI done? I think 2 years, if I'm not mistaken.
Yes, sir. Right now she is 2 years.
Okay, so we can see the head is small. There is some simplified gyral pattern extensively in the bilateral cerebral hemispheres. The thickness I just checked was around 5 millimeters, the slice thickness. So I'm not sure if the cortex is thickened or not, but it definitely appears simplified, especially you see over here in the frontal lobes. The sulcation pattern is not as what we typically see in a 2-year-old child. The central structures, the basal gang, the dorsal striatum particularly appears slightly hypoplastic. There's almost a colpocephalic type pattern appearance of the lateral ventricles over there. Coming down posteriorly, the main findings were in the inferior cerebral hemispheres. You can appreciate over here in the last 2 images, there is cerebellar dysplasia on both sides coming in the bilateral inferior cerebral hemispheres, whereas the middle and the superior aspects did not demonstrate any dysplastic appearance or volume loss. The brainstem, at least on the axial images, did not demonstrate any formation of any malformative changes. So supratentorially, I can possibly say that there is a simplified gyration pattern, maybe some degree of pachygyria, some hypoplasia of the central structures, especially the basal ganglia, and a colpocephalic type appearance of the lateral ventricles, with an overall small microcephalic head as corroborated with the clinical findings. Kernel sequences, again, you can appreciate the gyration pattern is slightly abnormal, coming from the anterior to the posterior aspects, and sagittal sequences, the corpus callosum is possibly slightly dysplastic. The mid segments are hypoplastic in nature. And there's also some degree of brainstem hypoplasia, especially in the pons. The vermis also, the vermis appear to be normal, at least in terms of volume, and no abnormalities in terms of calcification or mineralization to suggest a possible torch-like infection. So yeah, so the GRE did not reveal any hemorrhage or calcification. Again, T1 weighted sequences, this is not a thin slice sequence. Again, this was a 4 millimeter sequence, and similar changes with what we have seen on the T2 weighted sequences. We are thinking of a genetic disorder, maybe related to primary microcephaly related autosomal recessive disorders, but I could not find inferior cerebral hypoplasia, dysplasia related to a primary microcephaly or a severe congenital microcephaly related disorder. They are typically seen in the Chudley-McCullough syndrome, though can be variable otherwise in other disorders, but the typical finding in this abnormality is inferior cerebral dysplasia. But our child, I don't think, has hearing loss, and polymicrogyria or heterotopia are more commonly seen, and corpus callosum abnormalities. So thinking genetic, but I'm not able to point out to a particular disorder. So I'll open the case now.
I think in terms of hierarchy, this cerebellar finding is not really that important. I'm much more impressed by the supratentorial finding of malformation of cortical development in the broad sense, likely genetic. And if I may come back just with a simple clinical comment, when you look again at the first slide, before you call a 2-year-old to have normal cognition without any detailed testing, you are likely to be wrong. I mean, to recognize the mother, this is something which can be accomplished at the age of 2 months. So whether this has normal cognition, it's not important for the final diagnosis, but I have great doubt. And you should be careful to call this normal until you have specific developmental testing.
Any particular spectrum, Aigen or Dr. Soares, microtubulopathies or primary microcephaly related disorders, I guess?
I just want to comment on the cataloging of the abnormalities. I would have called these, as you described in more detail, but it's microcephaly with simplified gyration and mild cortical thickening. I think there is mild cortical thickening, plus the ancillary finding of inferior cerebellar dysplasia. So you showed Chudley-McLaugh, but in reality, when we catalog these cases correctly, they'll go to a microcephaly panel.
Yeah.
And the differential here would be looking for calcifications or any destructive lesion that could potentially be a cause, like congenital CMV infection, for example.
Yeah, just to summarize, I think overall we're thinking genetic because I'm not sure.
Yeah,
Yeah,
I completely agree.
got it.
Yes.
All right, thank you. Dr. Joy, I'm not sure if she's there. Dr. Sayani, are you there? Maybe you
Yes.
can take over. Yeah.
This is the case of one of my colleagues. So she's not here to present. The patient is a 6-year-old girl with acute onset right hemiparesis, and the child also had a right side human facial palsy with some mild encephalopathy. There was also a history of a febrile illness just 1 week prior to this episode. The child received aspirin and steroids during the hospital stay. And in view of the MRI findings, the child was discharged on oral steroids and aspirins. So post-discharge, there has been some improvement in the hemiparesis and the encephalopathy has resolved. Investigation-wise, the HB was normal, ESR was also normal, and ANA, lupus, anticoagulant, echo, everything was normal. So we can discuss the MRI findings. So her main question was, so after we see the MRI, we can ask.
Yeah, so we have these areas of infarcts in the peripheral regions, the cortical regions of the frontal lobes, the parietal lobes, and coming more centrally in the basal ganglia, the internal capsule, also the temporal lobe over there. So subacute infarcts predominantly involving the left MCA territory, I would say the M1 and the M2 segments. Corresponding changes on the flare sequences with these hyperintensities. No mineralization, especially in the basal ganglia, and no hemorrhagic findings. On the angio, we have the source and the MIP images. I could not put out the entire video, but what I could appreciate is that the internal carotid arteries were normal in caliber, but the MCA over here, you can appreciate in comparison to the contralateral side, is narrowed, or they're slightly irregular in appearance, the M1 and the M2 segments. On the MIPS, you can maybe appreciate here again, here the middle cerebral artery is narrowed, but the internal carotid arteries and the rest of the arterial system, I could not appreciate any findings. The neck angio did not demonstrate any areas of thrombosis or stenosis. So the question was, Dr. Sani, maybe you can ask the question and then I'll open.
Yeah, her question was mainly, so there are, obviously the pathology is unilateral, but the lesions on the MRI, like there's some M5-3 and some M1, M2 segments, some multifocal lesions were there. So her main question was if the MRA, if it would have not been done, then how to differentiate these lesions from demyelinating lesions.
Dr. Soares, do you want to take that up?
Yes, I think the distinction is not purely by imaging. One finding that makes me think of infarct is the incomplete involvement of the basal ganglia on the left. However, we do see that in basal ganglia and deep gray nuclei involvement with ADEM as well. But all these lesions that we're seeing have a left middle cerebral artery distribution, and that is the vessel that is narrowed on the MRI angiogram that Nihaal showed. So although there is no 100% certainty, I would think that these are most likely ischemic lesions. There's also a comment in the chat. Whole of the lesion will restrict an infarct, while demyelination only peripheral restriction. That's a perfect observation, and I believe that we had the whole lesion restricting on the diffusion, correct? Yeah, this patchy restriction is more characteristic of ischemia than of demyelination. Of course, we could also inject contrast and look at the pattern of enhancement if it's patchy or any target or incomplete rim of enhancement, but this looks more like ischemia to me and all fitting the territory of the involved artery.
The other question I think was looking at vasculitis and the inflammatory markers were normal. Is that right, Dr. Sayoni?
Yeah. The inflammatory markers all were normal.
I think might be, yeah. Sorry again. Go ahead.
I think some people would call this transient focal arteriopathy.
Correct.
Which means it has it may have an aggravation in the near future, but it has a good long-term outcome overall. And there is a debate, there is a study going on whether steroids are in fact useful or not. It's often given.
Yeah.
Yes.
So I was sort of involved with this patient briefly. So the confusion when this child presents on day one with angio is how can you differentiate between a thrombus and a FCA? Because if you don't have wall imaging, so decision is to in the night, if a child comes with this imaging, do you start him up from steroids or you give him Clexane for a few days, so any markers which can help you, this will be more like inflammatory FCA rather than a thrombus, small thrombus.
I'm not sure whether I can give you a complete answer. Transient focal arteriopathy is commonly, one common reason is varicella in the few months before. And then if the one patient died and you could have a histology of that area and you see an inflammation, but it's not a general vasculitis.
So just to mention, if I see 10 FCA, in 8, I will not have history of varicella, or even 9. So maybe that's just based on few papers which has been latched upon. That's what I feel. And mostly you don't get the history of varicella. So if you have a child who presents like this with no history of varicella, which is mostly the case, thrombus versus a FCA, because steroid, aspirin, or Clexane alone.
You mean thrombus without angio? Is that the question?
With the angio.
Okay, with the angio, there will be a cutoff of the vessel. The distal flow is not as evident as seen in a vasculitis, which has only a peripheral narrowing.
Right.
So yeah.
Because often you don't get a history of infection. So this child, no history of infection, no fever, just acute onset, morning hemiparesis presented within 6 hours, 4 hours. So one would be wondering whether to, do something. If there are centers which can do the thrombus could be removed and all that. So that sorts of confusion. So you mean that if it is a thrombus, the distal part will be tailing off, while if it is a FCA, you just see a small narrowing. Is that how you differentiate?
Yeah.
Right. And will there be?
And if you have
more-
resources, then you can get a vessel wall, and that will show some enhancement peripherally. But if
The
you only have,
problem with most centers is one
Yeah, I
can get
understand.
vessel wall
Yeah.
imaging, but the interpretation is a problem.
okay,
Which is
but I
easy,
think this
but
is
slow.
sufficient. The focal narrowing with the distal flow, more narrowing along the peripheral aspect, which is suggestive of a wall inflammation. Thrombus usually have a cutoff, and the distal flow is not as evident as seen in our case over here.
Okay, and can you have small, like the one you see here in M1, distally also one can see these in arteriopathy, if it was there?
It is there over here.
It's not there in this patient, but you will see similar sort of finding in the distal segment of blood vessel that can also be there in arteriopathy, or usually it's only in the proximal part.
You mean in terms of the FCAs?
Yes, yes,
Yeah, by definition, they're usually in the proximal parts.
proximal part. Okay.
And the transient and the chronic would be on a follow-up. 6 months is the time period.
Yeah, that's a retrospect.
That
So that doesn't help.
Diagnosis. Yeah,
That
yeah.
doesn't
But
help.
they're usually proximal. The ICA1, M1, so the P1 segments over here, as highlighted here, it's usually the proximal segments for a focal cerebral arteriopathy. And this would be the inflammatory type as outlined by, I think, the group working at Stanford, if I'm not mistaken, Dr. Soares from Dr. Wintermark's papers.
Yeah, that's correct. Max did some of this work here. He's in Houston now,
Oh, okay.
and also Heather Fullerton and the child neurology group at UCSF have been doing most of these longer, bigger trials with kids with AIS.
There was a mention, can CTA help to differentiate thrombus from FCA?
The CT angio, the contrast angio will give the same findings as the MR. A cutoff for a thrombus and more peripheral abnormalities for vasculitis.
Yeah, and we've been also looking at the role of arterial vessel wall imaging.
Yep.
So doing a very thin slice volumetric T1 pre and post contrast to look at the enhancement in the wall of the artery. And but we get the same dilemmas as with some osteomyelitis, for example, in which how much enhancement do you need to have to stop treatment? How much resolution should you expect? And we're still learning that.
Right. Thanks, Dr. Soares. Thanks, Dr. Vivek. We'll move on to our last case. Dr. Sayoni, again, over to you.
Yeah. So we had a 7.5 years old boy who actually is a known case of thalassemia major and was on regular blood transfusions. The child has a global developmental delay in all the domains and had intellectual disability following. So the child actually presented to us basically with a continuous high-grade fever, which was around 105 to 106. And along with that, he also had coarse tremors, predominantly of the head extremities, both at resting and also with at a kinetic component too. The major changes, he was not cooperative for detailed cognitive examination, but he had some recent memory issues, which was not there as per the parents since before. On examination, the child actually had Parkinsonian features with cogwheel rigidity, tremors, resting kinetic, bradykinesia, and wrist DTRs. The sensorium, however, there was no significant change from previous. When we did, Dr. Nihaal, you can show the MRI findings because that was the first. So the initial routine workup, infective workup with a CSF, with the blood, everything, CRPS or everything was normal. So initially we progressed, did an MRI. So we can discuss the MRI findings and then the.
Okay, got it. Into day of illness, Dr. Sayoni?
This was around 5 days of illness.
Right.
Day 5 of illness.
So yeah, on the T2 and the flare sequences, you can appreciate the striking abnormalities in the central structures of the brain. The globus pallidus are edematous over there, bilateral symmetrical abnormalities, the midbrain in the cerebral peduncles demonstrate these hyperintensities. Some areas of periaqueductal abnormalities over there on the tegmental regions have these T2 hyperintensities. Similar corresponding changes on the flare sequences, just to highlight also there was some hyperintensities over there around the dorsal pons and in the middle cerebral peduncles. And again, the flare sequences demonstrate the abnormalities which we have seen on the T2 weighted sequences. There is some degree of sulcal prominence, some cortical reduction in the frontal and parietal lobes, but the predominant changes are in the central structures. I would also possibly argue that the folial spaces are slightly prominent in the vermis on both sides. On the diffusion weighted sequences, the hyperintense foci demonstrate restricted diffusion. All of the regions demonstrate these areas of restricted diffusion. And the GRE or the SWI did not demonstrate any hemosiderin or calcification. There were some areas of hemosiderin lining in the ventricles and also in the CSF spaces, but not within the abnormal foci, which was seen on the T2 and the diffusion weighted sequences. Contrast study done, I cannot appreciate any significant enhancement in the abnormalities, and no meningeal enhancement and no CSF or no extraaxial enhancement demonstrated. And based on that findings, these are the differential which we think of, given the main changes were in the globus pallidus and also the brainstem. A spectroscopy wasn't done for this child, but the main findings or the main difference.
This was not done.
Yeah. So main findings we are thinking of is, given the lactate, metabolic acidosis and increased lactate, are the mitochondrial disorders, pyruvate dehydrogenase deficiency usually has, or respiratory chain disorders has these involvement of the central structures. Fatty acid oxidation disorders also can have similar findings. We have seen a few cases of medium chain and long chain fatty acid oxidation disorders, which have these central abnormalities. Beta-ketothiolase also has these findings. MMA, again, an organic aciduria, which can have these central abnormalities. I think connectors, isovaleric acidemia, and SSDH can be ruled out. Creatine deficiency also, not sure they demonstrate diffusion changes. They can have hyperintense changes in the globus pallidus. Again, spectroscopy is helpful. So thinking, at least on the radiological basis, thinking more of an environment of metabolism, a genetic disorder versus a primary infective related disorder. And then we'll go back to the patient's video if that's all right.
So after the MRI, so neurometabolic, as Dr. Nihaal suggested, that was the first possibility. So the blood gas had actually shown that there was some compensated metabolic acidosis with a raised lactate. Lactate was around 4 in the venous blood gas. However, the TMS, DCMS turned out to be normal. And this child actually continued to have persistent high-grade fever. So Dr. Nihaal, there was, I think also there was a lesion in the left hypothalamus.
Not on these images. Maybe over here, the subthalamic, hypothalamic region bilaterally have these changes.
Was the child on deferipon?
No, sir, the child was deferasirox, sir.
Because I had a patient who was on deferipon or deferoxamine who had similar symptoms and signs and some similar MRI changes. And after stopping the desferoxamine, things started to improve significantly. So I'm not saying that this is the case here, but that is one possibility.
Yeah. So, sir, this child was actually on deferoxamine 1 year back. He was given for, I think, around 3-4 months. Following that, he developed actually an ocular myasthenia. So that was mostly attributed to a drug induced. But before that also, sir, he had this global development and intellectual. But after that, that time I don't have an imaging.
So now he's on desferoxamine or not?
Sir?
Is
now,
he on desferoxamine?
I mean, that was stopped even only
So
for
any chelation therapy.
He's on chelation, sir.
So he's on deferipon then?
Ah.
Yeah, deferipon, right? He's not on desferoxamine, he's on deferipon. Is that right? Because he's on a chelation therapy, desferoxamine caused ocular myasthenia, so he's on deferipon now.
Sir, Decifer he's on, sir, the other one, sir.
Yes, that was the one which caused problem in my patient.
Okay, sir.
You know, the newer one, deferipon is the newer one, Decifer or deferipon.
Yes, sir, there are 3, sir, actually. Deferoxamine,
Okay.
So he's on, sir. I think, sir, you are talking about deferriprone, but this child is on deferasirox, sir.
Okay.
So the injectables are desferoxamine. 1 year back, he had developed, like after 3 months, it was attributed, he was treated outside. So he was attributed to a drug induced, and after the drug was stopped, the child recovered also. He required very low doses of pyridostigmine. RNST was suggestive. That time antibodies were also done, but those were negative.
Because there must be something related to the drug then, because he had this similar problem a year back.
Yes, sir. So,
I think the ocular myasthenia presentation, at that time they didn't do the MRI, isn't it?
nothing was done. So, but
Yeah.
in child, we also got a history that, 2 years back, the child had an episode of dengue. That time also he had some coarse tremors, and the mother also complained that time also there was some stiffness in all the four limbs, but that resolved in 2 weeks time. But this time the child just presented with a continuous high grade fever. So initially we did all workup infective, everything was negative. So, but there was a lesion in the hypothalamus. So we ultimately attributed it to a central cause of fever and gave bromocriptine to that. He responded to some sort, but still he has 100 fever, sir, even after 2 weeks. So my question was mainly that
this is not going to be
sir?
This is not going to be infective pathology.
Yes, sir.
This is something related to all the 3 episodes, very likely.
Yes, sir. Because of that high grade continuous fever, like 105, 106, there was a persistent fever, which was there almost for same fever, not going to baseline for 2 weeks, sir. So, sir,
Can RANBP2 mutation be there? Can it present without thalamic involvement? Because I had a patient who just had unilateral putamen involvement. So, RANBP2 underlying.
No hemorrhage, more extra capsular for NBP2, as far as I know.
I just had one patient who just had similar febrile encephalopathies, 3 episodes, and just one putaminal lesion, not even extra, and he had RANBP2, not like the classical dengue. A&E, no A&E. So it's just the possibilities if it is drug induced, which is a big possibility, and some underlying tendency to deteriorate with a febrile illness.
Dr. Vivek, just one question. The patient that you are talking about also have hypothalamic involvement?
No,
this initial patient
he had globus, some globus involvement in midbrain, and he had this Parkinsonism at that time. That child also had that.
And this child also has Parkinsonian features, but he's very unusual in the sense that he's just, the hypothalamic involvement confused us a lot, because initially with such high fevers which did not respond to anything, initially was managed by the pediatrician as all sorts of infective pathologies, antibiotics.
The hypothalamic lesion has to be the same process as rest of the things. So we cannot just
must be
just point it out separately. So, it has to be the same process.
Yeah, it must be part.
There is some involvement of the hypothalamus on the center flare image, right, Nihaal? And then on the one on the right hand side,
but
the medial aspect of the hypothalamus.
Along with that,
there's also prominent periaqueductal involvement on this on the third image. Yeah, tissue. This looks like a mitochondrial disorder, or and perhaps resulting in some kind of acidopathy. I'm fascinated here because I don't have experience of drug reactions causing these patterns specifically, and all this swelling of the globus pallidus. We all know, for example, vigabatrin can cause restricted diffusion in several of the deep gray nuclei, but typically it's diffusion restriction without any swelling. The impression I have when I look at the globus pallidus and it's so swollen is that this is acute injury and will progress with atrophy on the follow-up, not reversible restricted diffusion.
Can thiamine deficiency cause it in some?
At least as far as I know, the thymines are more dorsal striatal involvement rather than globus pallidus. And the cortex is also sometimes involved.
Right.
But I think being common, we are looking at an inborn metabolism, mitochondrial, as Dr. Suarez has mentioned, and fatty acid oxidation, beta-catechols, MMAs. I'm not sure of the drug-related changes, as I have not have not seen a case, but
PMS is normal, right? They
Yeah.
said
Yes,
PMS
sir.
is normal. So fatty acid is out.
Yes, sir.
Okay,
So the
okay.
ketones were negative, ammonia, glucose was normal. Only there was a compensated metabolic acidosis with a lactate around 4.
That could be dehydration at the time. Did you repeat?
So, yeah. So we repeated even after 3-4 days, sir. It was almost same. There was just the bicarb had improved. Initially, it was 10, maybe it increased to 11 or 12, but not more than that, even with fluids and all.
Yeah. Dr. Krishna mentioned in the chat that the mild cerebellar atrophy also suggests mitochondria, which is a very pertinent comment.
So, Dr. Vivek, I just wanted to ask, did your patient improve on stopping the drug? Like, so Dr. Nihaal, I think Dr. Vivek has left.
Okay. So yeah, I think we are thinking of, as in the chat also, mitochondrial as the primary possibility. So
Yes.
the child has been sent for genetics, right? If I'm not mistaken.
Yeah.
Yeah. Okay. All right. Maybe you can give us a update once you get the results.
I will, I will update about the follow.
All right. Thank you. And that's our last case. I apologize for the technical issues in between. Thanks, Dr. Suarez, for taking up the slides in between. And thank you for joining us today. I know it's early in the morning for you. We'll again see you on the 4th of August. Please do send us your last cases by the 2nd of August, and you can email me on that address. So once again, thank Aigan, Dr. Suarez, and all the panelists and the attendees for joining in.
Thank you. I learned a lot today.
Thanks, Dr. Suarez.
Thank you. Very good discussion.
Thank you, everyone.
Thank you very much, and see you in 2 weeks' time.